Through our research, we have found that IV fluid therapy in the pre-hospital setting is time-consuming and not beneficial to most patients who receive it. Currently in QAS, we use 0.9% sodium chloride, and it has many indications for adults and pediatrics. Sodium chloride is used as a fluid replacement and electrolyte replenisher. Saline is a crystalloid fluid, however there are also colloids that can be used, just not regularly in a pre-hospital environment. Colloids are a higher molecular weight solution that increase plasma oncotic pressure. Colloids can be classified as either natural or artificial. Due to their higher molecular weight, colloids stay in the intravascular space significantly longer than crystalloids, such as sodium chloride 0.9%. Although there is a general agreement that volume therapy is an integral component of early resuscitation, there is a lack of consensus for the type of fluid, standards of volume assessment, and endpoints. In this presentation, we are going to cover some of the main instances where fluid therapy could be unnecessarily administered. Pre-hospital IV fluid therapy is still regarded as one of the main primary treatment options in trauma-related cases. Dresky, Burles, Bayliss, and Sandercook in their 2006 study state that one of the leading causes of death in trauma in patients is hypovolemic shock, which is a result of insufficient tissue and organ perfusion and circulatory failure due to hemorrhage. IV fluid therapy is believed to work by replacing the lost intravascular volume, which helps maintain the blood pressure and maintain organ perfusion. Research shows that penetrating and blunt trauma injuries treated with high volume fluid replacement resulted in longer rescue times and higher mortality rates. While some advocate for field stabilization prior to the transport of the patient to hospital, others believe in the scoop and run method, as they believe that on-scene IV fluid administration cannot replace the volume of blood red cells lost in severe trauma cases. According to Deacon and Hicks in 1994 in blunt trauma, most patients that become dangerously hypertensive do so because of internal bleeding. Treatment for such injuries is beyond the scope of practice for paramedics and is not controllable without surgical intervention. Therefore, rapid transport of the patient to hospital will increase the chances of survival for blunt trauma patients. Adequate tissue perfusion in penetrating and blunt trauma patients is a key area of focus for paramedics. Some authors suggest that high volumes of fluid will improve tissue perfusion. However, Davenport in 2013 states that excessive blood loss and hemodilution due to fluid therapy actually exacerbates the coagulation response and leads to trauma-induced coagulopathy. An article by Dresky et al. In 2006 states that IV fluids dilute the clotting factors in the blood and cause mechanical disruption of blood clots due to the increase in blood pressure. Furthermore, the increased blood pressure impairs the body's natural response to trauma, which diverts the blood away from the extremities and towards the major vital organs. An early study by Bickel et al. In 1994 showed that delaying intravenous fluid therapy in penetrating trauma patients resulted in significantly higher survival rate in comparison to immediate fluid therapy. In this study, fluid therapy was delayed until the patient entered the operating theatre, and immediate fluid therapy was administered on scene by the paramedics. A study in 2011 by Hort et al. That reviewed 35,664 patients discovered that those who received higher volumes of fluid had longer intubation time periods, spent more time in ICU, had lower hemoglobin and prothrombin levels, and consequently required more units of blood compared to those who received low volumes.
Created using Powtoon.